It's a wonderful talk that Alexandra has given before, because this is an example of a doctor, happens to be a professor of obstetrics and gynecology, who has observed that endocrinology and reproductive endocrinology may just be at the heart of this business of reproduction. And while the rest of us have been busy in the laboratory doing admittedly good things, and the urologists have been arguing about varicocele, there are some startling revelations about the importance of our hormones. Alexandra, over to you.
The starting of the problem is just to understand how lot of the strategy of getting ovulation and pregnancy might be focused. And the very starting point is that everything is inside our brain, in female brain, obviously, and that the functions of the hypothalamus and all the tropins that are secreted from the hypothalamus and are directed towards hypophysis to get a result in the secretion of hormones are in very, very ways affected by the production of neuropeptides, neurosteroids. Also is unbalanced and modulated by a lot of hormonal disease, but also from metabolic diseases. And all such things affect the hypothalamic functions and GnRH production. Obviously, the things that we have to keep in mind that the evolution of the human being is a little bit complex. And even though, well, history started 5,000 years ago, more or less, well, everything started 4 million years ago, when Lucy, a small woman, 1 meter and 20 centimeters high, was just moving in Africa. And the way of lifestyle of such men was completely different from ours. Well, the surviving was completely different. As you can see from this very easy cartoon, things were starting to be during the Roman Empire, and with the evolution, the brainstorming, the technology, the ability of logics, so that to maintain and to produce food were probably improving our survival. Well, these things has to be kept in our mind when thinking about male and female of today's. Well, everything is completely different. It was completely different during 20,000 years ago way of surviving. You have to hunt for food. Probably you were getting food in average once in a week if you were lucky, but not every day, 3-4 times, thanks to the market, thanks to whatever you have, just to get food and to eat what you want. So everything was really related to the ability to find the food and to the biology to store the food in a precise way, so that 80% of the food that you eat now were kept and stored, and 20% probably was left to be used immediately. Well, everything was changing in the years, but everything was ruled by the lack of food. And everything was probably going on still nowadays in our biology, since we have learned to produce food in the last 3,000 years. Well, you have to think about that the last evolution in the biology of our body was more or less 300-400 million ago, when adrenal gland started to produce the hydropiandrosterone. And that's the really great acquisition of the human being. No other greatest biological changes has been done through the evolution up to now. So whatever we have now in our biology is regulated and modulated by our ability in the logical production of food, but not related to the ability of our biology. Is an incredible story, and if we go through the ability to understand how our body is responding to the changes, everything is changing, but our biology is accommodating the response. We have nothing different from these old, quite old men of more or less 30-40 million years ago, 1,000 years ago. So The production of food and the hunting for food to survive was the first thing. And whatever we get for food was stored to preserve the ability to go on surviving in the following days. But the stressors were modulating the life of the male, but mainly of the female, since the amount of food was incredibly important to get the amount of food and energy in the right amount just to have reproduction. And reproduction is rather important since the stressors are able to induce inside the brain specific responses. But you do not have to think about stress as a negative element. It's a very important. Is an accommodating element that makes you be able to cope with a completely adverse environment. And today the stressors are completely different for females. You do not have to hunt for food, you have to go for shopping, you have to go for dieting if you have a little bit of excess of food, you deprive your feeding, you reduce your amount of food, you have diet. But you might have stressors also on the neuropsychological aspect, familiar problems, maybe psychological weakness, inability to cope with your colleagues. All these things are completely different, but are in the same way similar to those of the very old female of 20,000 years ago. Everything was hitting the cortex of the brain, and everything was induced as a response so that to cope and modulate the ability of the hypothalamus to decide whether or not to go for reproduction in that female. And this is what we are really addressing now. Whatever are the changes inside the hypothalamus were not just to punish that female, but was just to create a defensive system to blunt the production in a moment that the female was not able to have as a good one to reproduce, probably for the excess of stressors, the reduction of food, the inability to find enough food, and getting pregnant is incredibly amount of energy needed. Think that every single day during pregnancy, you really need more than 3,000 calories. And in 20,000 years old story, it's difficult to get such amount of food. So when we are trying to address nowadays a similar condition in women, the only example with no organic disease that we have is the hypothalamic amenorrhea, something that is induced by stressors and not induced by systemic causal factors, no nervous system diseases, and not obviously by other endocrine diseases. Such functional hypothalamic amenorrhea is a sort of cloud, incredibly cloud of brainstorming of elements, neuropeptides, neurosteroids affecting the neurons secreting inside the hypothalamus GnRH, the only molecule able to stimulate the production of gonadotropins inside the pituitary. But we have to think about that if the hypothalamus is not producing enough GnRH so that to blunt the amount of LH induced inside the hypothalamus, that is not the only element that is affected by stressors. As you can see here, whatever are the changes in the metabolism and are able also the stressors induced in that female are able to cope to induce a negative amount and production of neuropeptides. And all these are able not really to blunt or to affect negatively GnRH, but also another amount, a great amount of neuropeptides and tropins produced by the hypothalamus and somehow affecting the production, yes, of LH, but also of adrenal gland with an increase of their functions, thyroid with a reduction of a function, and affecting also the production of prolactin and GH. So as you can see here, the brainstorming that you might have when stressors are affecting the hypothalamus are able to first block the production of GnRH, the gonadotropin releasing hormone, but the exaggerate activation of the adrenal gland axis create an enormous amount of cortisol, which is affecting in a negative way the control of GnRH production, so improving the negative signal inside the hypothalamus. Well, when clinically we try to consider what is going on in these women, and we just want to do minimal examinations, if we check cortisolemia in the blood in these patients, you find that only the patients with stress-induced hypothalamic amenorrhea have a high level of cortisol in the blood, which is not really hypercortisolemia, but is close to the upper limit of cortisol. And this is not in the control groups, or maybe in those affected by hyperprolactinemia or by the classic hyperandrogenic amenorrhea. Well, there are tight relation between the amount of cortisol and the amount of LH, but mainly the amount and the amplitude of LH pulses, which are relevant for reproduction. The higher are the cortisolemia, the lower are the amplitude of pulses in these patients. And the other relevant aspect is that if these females are not fed in the right way, they are not getting food as they are expected to do, well, the body weight reduction and mainly the amount of fat which is reduced is able to introduce the problem of first blocking the ovulation and later on blocking completely the menstruation. Well, we started trying to understand in the last 10 years what was going on in the reproduction in the animal model, and we decided to check what was going when stressors were affecting reproduction and when we are trying to use carnitine as a positive modulator and protector of this stress-induced unbalancing of reproduction. Well, we found that whenever the animals were exposed to stress, you have the reduction of GnRH inside the hypothalamus, but you have the reduction also of gonadotropins. But if you give in the water in these animals the carnitine in the right amount per kilo, you find that such reduction was completely abolished and the animals were not characterized by such impairment. But why carnitines were important in this moment? Well, they are very well acting inside the beta oxidation in the production of energy using the free fatty acids and mainly inducing the production of ATP in all the cells, mainly in one specific group of cells, those inside the hypothalamus. And this is relevant since the animal model is fitting with the human model of patients with functional hypothalamic amenorrhea. Well, almost 16 years ago, from my very first idea from my director of the department of those years, that was my brother, but now we are working in completely field differently, but he started saying that probably carnitine were relevant, and we tested this in a very simple protocol, just giving acetylcarnitine in these patients for several weeks, almost 5 months, and we found that, as you can see here, from very low levels of LH, carnitines were able, with no changes in the lifestyle, to induce little by little the gaining again of the normal pulsatile release of LH. And several years ago, we started again to try to understand what was going on with the use of carnitine inside the hypothalamic modulation, and we decided to test again a group of patients with functional hypothalamic amenorrhea, and we tested the naloxone test in these patients to see the response in LH. As you can see here, this is the presence of no response before the treatment with acetylcarnitine, and later we again get the release of higher amount of LH in basal conditions, and we get the response of LH to naloxone. But look at the delta of LH before and after the integration, and look the area under the curve of the naloxone test. Well, this was clearly saying, yes, carnitines are relevant for reproduction. Relevant in the sense that are protecting the neurons and probably are improving the ability of the neuron to be able again to produce GnRH so that the hypophysis can be stimulated to the production of gonadotropins. But in the years, the evolution of science and of the pharmaceutical companies and also the brainstorming with the researcher gave us a new tool, which is a completely different approach with integrations with acetylcarnitine, with levocarnitine, with arginine and N-acetylcysteine that complexively combined probably might be helpful in such patients. And well, we tested this. It's a very easy experiment. We gave this small sack to be kept every day in the morning in these patients. The group was 27 patients with a functional hypothalamic amenorrhea, and in the whole, these are the results. We have a slightly significant increase of LH. We have no other great changes, a little small improvement of body mass index. You know that these patients have very, very narrow limits of body mass index, which is usually close to 19, not so much high. But what were the great changes? Well, the changes were well evident when we split the group in two parts according to very simple observation, something that we made a lot of years ago, that if you split the patients according to the levels of LH, which is those with LH levels above 3 and those with LH levels below 3. This is a cutoff that has been established almost in the 90s, and we saw that the treatment with carnitine, levocarnitine, acetylcarnitine, arginine, and acetylcysteine were able to determine great changes in the group with very low LH levels. A greater improve of LH, but look at this. We have the decrease of cortisol, a little slightly improvement of body mass index, but mainly the decrease of amylase. Well, whoever of you had to face the patients with functional hypothalamic amenorrhea know very well that these patients are very difficult since they are not classically with the will of changing their lifestyle. They do not want to change to keep contact and control with food. So these patients had a very slight improvement of body mass index, probably because we have the ability through such combinations to improve the ability inside the hypothalamus to better use, store, and induce the production of energy on one side, of the right hormones for reproduction on the other one. But only those that have LH below 3, those with above 3 were not affected by such improvements. Why? Very easy. Those with 3 or below 3 were the same kind of patients, but kept and photographed in completely different moments, at the starting of the problems and quite later in the problem, when the hypothalamus was greatly bored by the fact of being affected by stressors. So they are more severe patients. Well, if we check in these two groups of patients the response to the GnRH standard test with 10 micrograms, you see here that the response before and after the Proxeed treatment were incredibly different. You gain again the ability of the hypophysis to respond to the stimulation. No changes in the other patients, since in these patients the damages are not so severe, and so the system is still working not really properly, but quite good, So the story is very important now. Well, we are a completely incredible cloud of genes, all encoded one with the other one, and we are obviously working perfectly. But whenever we have to think about the female today, we have to keep in mind that if genes are working and the biology have already set what is the standard of the working, well, the epigenetics and the behavior of our style of life probably will make the difference. And this make us think about something else, something that probably none of you have a little bit thought about, but probably these lean patients with functional hypothalamic amenorrhea are not so different from those with obesity or polycystic ovary syndrome. This means the excess of weight or the reduction of weight are able, in the same way with different equilibrium, to affect the reproduction and to affect the hypothalamus. And so we developed a little bit another idea. And I want to show you for the first time, you are the first one to see this data with preliminary data of the use of the same compound that we used for functional hypothalamic amenorrhea in patients with PCOS. And you know that polycystic ovary syndrome is a quite complex, complicated, intriguing syndrome. And you know very well that according to the countries, you might have a quite important percentage of females affected by it. And you know all the aspects of polycystic ovary. You know that you have amenorrhea or maybe oligomenorrhea, hyperandrogenism, but mainly you have an altered body mass index, an excess of weight, and mainly hyperinsulinemia. These are triggering important aspects since the excess of insulin, obesity, you can see this in this cartoon, are able to induce somehow, obviously, a lot of diseases with the passing of time. And we have to keep these under control. And polycystic ovary syndrome, you know, the Rotterdam's criteria, are quite common all over the world. In between 5 up to 20% of the women have polycystic ovary. And you know very well, this is a very well-known paper, that hyperinsulinemia is the first one that seems to be the fil rouge driving all the aspects of the worsening of the prospect of life in these women if they have polycystic ovary and hyperinsulinism starting when they are young. Well, insulin sensitivity, when reduced, improves the ability of cardiovascular disease. So this might suggest to all of us to keep weight under control and to stay very attempt to what we are going to have as food. But recently, a lot of papers have demonstrated that these patients with PCOS have a defect in carnitine. Oh, that's interesting, triggering. And this is intriguing also in the way of thinking about these patients. And later studies have clearly demonstrated that if you give carnitine to these PCOS, you improve a lot of aspects in the metabolic aspects of these patients, which is a little bit unbalanced, but mainly you induce some changes also in the insulin control and the insulin sensitivity. So we decided to test again the use of this combination, which is well known as Proxeed in these patients, just to see what kind of effects we might have in a completely different population of those with functional hypothalamic amenorrhea. So we just started, and so these are very preliminary data. We have a very small group of 15, 16 patients, as you can see, but well, we gave this treatment for 12 weeks, and we were quite interested from the results. Since we got that we have a reduction of insulin, we reduced slightly the total cholesterol, the LDL was a little bit improved, and mainly, look at here, we have an improvement of OMA index, but no lifestyle changes was asked to be followed by these patients, as we made for functional hypothalamic amenorrhea. And astonishingly, we also tested another important aspect, which was just to understand what were the history, the familiar history of these patients. And we saw that if we check those with a familiar diabetes and those with no familiar diabetes, there was a quite regular distribution. But when we checked the patients according to the level of insulin in baseline conditions, we found that the higher changes were in those with the hyperinsulinemia in baseline conditions, especially for total cholesterol and also mainly for OMA index, which are very preliminary data, but mainly these patients were with hyperinsulinemia and familiar diabetes together in the same time. So this clearly gives the idea that probably the administration of our carnitines are really affecting and probably remodulating the ability of these patients to have a better control of the metabolism, especially that induced and modulated by insulin. These are the response to the oral glucose tolerance test, as you can see, the whole group here. And these are the responses when you see the differences in those that had hyperinsulinemia in baseline or just normal insulinemia. Well, as you can see here, Under the oral glucose tolerance test, which is almost a pharmacological test, you have a great improve in baseline condition, but you have a 50% reduction of the response, which is really important. And this is the really important message that we can get in these patients, since probably the right amount of carnitines administered here, together with N-acetylcysteine or levoarginine, which are the other compounds and other integrators added in this preparation, are able to affect somehow the modulations. Well, the same story is if we check another aspect, which is typical and classic in these PCOS patients. If we subdivided the patients according to the fact of having the insulin in baseline conditions higher than 12, which is the cutoff already assumed to be the bell that give you the idea of having patients with a risk of hyperinsulinemia, well, those that have the levels in baseline conditions higher than 12 are able to have a better response with the Proxeed administration. Where is the story? The story is here, that probably Proxeed is improving the metabolic energetic ability to produce energy as ATP through the beta oxidation, and the other two compounds, N-acetylcysteine and arginine, are able to modulate the expression and synthesis of nitric oxide in these patients, which is able to induce somehow changes in the endothelial ability to be affected in the control and in the modulation of glycemia and insulin. So just to give you an idea and a conclusion is that probably we have now something which is integrating in two completely different populations in the best way, in the better way, the ability to get control of the reproduction on one side and on the other one of the metabolism, which is relevant since our biology needs a perfect balanced metabolism to be able to reproduce and to cope. The other problem is that we have to balance genes with behavior. So keep calm with the next happy hour time. Thank you.